Welcome, friends. It is our great pleasure to introduce you to SICOT Pioneer. Pioneer is a program of innovative orthopedic networking, e-learning, education, and research that was designed to fill the gap left by the absence of face-to-face meetings, courses, and other activities during the 2020 coronavirus pandemic. But Pioneer has become so much more than this in the intervening year. Pioneer is a virtual, but also very real community of like-minded orthopedists striving to help not only themselves, but one another. With the latest video conferencing and educational technology, as well as a groundbreaking online platform, SICOT's Pioneer events, activities, and resources are reaching every corner of the globe, with over 55,000 views of our webinars so far. We're forging new partnerships, signing agreements with 12 other international academic societies, and building an enduring network we hope will last for many years to come. So, what can you expect from us? Free webinars led by key opinion leaders from around the world and across all fields of orthopedic surgery and traumatology, as well as chat shows with some of the most interesting and inspiring surgeons on the planet. Opportunities to take an interactive role in these webinars by participating in polls and live discussions. Free on-demand Pioneer playback service. Watch our webinars again and again in your own time. And coming soon, our new bespoke learning management system will host podcasts, an online version of the famous SICOT diploma exam, virtual training modules, surgical technique courses, a discussion forum, and much, much more. We hope you'll join us on this pioneering journey as we push the boundaries of what is possible in online orthopedic education together.
So a very warm welcome to all the friends and colleagues from all over the world. Good morning, good afternoon, and good evening to all of you. I'm Fabio Sciarretta, speaking from Rome, Italy, and I'm the actual editorial secretary of the SICOT Society, and I'm very happy to welcome you on this very interesting event that our friend Hassan Smerli has studied and proposed, speaking about the painful knee joint and especially focusing on all the problems that synovial membrane can cause. Together with me, he will be moderating the session Dr. Ghazi Yuri from Aksatepe University in Ankara. And I'm from Turkey, and I'm very glad to leave the word to him. Please, Ghazi.
Thank you very much, Fabio. First of all, good morning, good evening, good afternoon to all over the world, to our SICOT followers, and welcome to our pioneering journey. It's Ghazi Yuri from Ankara, from Turkey. I'm a sports surgeon and focused on the shoulder and knee as well. So I just want to start up with the first speaker. I want to invite Dr. Francesco Pegreffi. He's going to present the synovial membrane and the sport. Thank you very much. Please.
Good morning. Thank you very much. Good morning. I'd like to express my deepest appreciation to the organizers, to Dr. Smerli, and I'm gonna go to speak about synovial membrane, that is specialized connective tissue that lines the inner surface of capsules of synovial joints. So just to give you an overview of the functional anatomy, passing through microscopic anatomy to histology, and we can discriminate two layers that has different functions. The inner layer that's straight in contact with synovial fluid, and the external layer that is adherent to the capsule. So concerning cells, they are really very vascularized, and just going back to the histology, to understand the function of this very interesting tissue. We can discriminate type A and type B cells. Type A cells are macrophage-like synovial cells that have the function of phagocytosis. So removal of undesirable substances from the synovial fluid. And type B, fibroblasts-like synoviocytes, have the properties of restore the joint environment, secreting hyaluronic acid and proteins. So given that, we are ready to face how synovial intimal cells act as functional tissue. Because if we consider the anatomy and we consider the structure, we can really understand how these cells are detectors of physical activity intensity. So from physical activity moderate to sport through morphological adaptations. So there is a stress given by articular movement, weight bearing, and we have like during, for example, moderate dynamic condition, we have primarily cilia that we have seen before that start like changing their environmental like the environment of the joint, acting like chemo receptors. They triggers some reactions, a plethora or reaction that sometimes we really we don't know, but we and are not still investigated. But we know that environment changes in the something called anti-inflammatory mechanokines are like released in the synovial fluid. And I mean, I am speaking about IL-4, IL-10, IL-13 that also have the properties of inhibit type A synoviocyte protecting from destructive cytokines like IL-1 beta and the TNF alpha. So there is a really very complicated complex that if the physical activity is like moderate, so physical exercise is beneficial. But let's go to analyze sport activity that sometimes is characterized by injury and overtraining. And in response of injury and overtraining is hypertrophic response and irritative response that this uninvestigated tissue acts. So this is what I see in my office when an athlete overtrain, something goes wrong, and you see that there is an overproduction of synovial fluid to protect the joint. So there is a response of our synovial tissue. And let's classify the type of injury that it can be acute. So yes, we proceed to treat, for example, the cartilage lesion, and then we take care of the synovium. Or what I am investigated on is degenerative, so overloading. It's something chronic, it's something that progresses through time. And this is another issue, very important, I want you to address, the crosstalk between synovium, cartilage, and bone. Because synovium do not act alone, but there is a strong interplay between cartilage and synovium. And it's what we see when we classify, for example, an arthritis at the beginning, osteoarthritis, and we are concentrating to pre-grade 0 Keller-Granelloran classification that we see here in the movie. Checking the X-ray, the patient is a healthy patient, but there is a response of synovitis, of synovium. And this is occasional synovitis that shows how the wear and tear theory of osteoarthritis is like to be melted to synovial inflammation theory. So a lot of very important observation that in ordinary surgery we do every day. Here, for example, you see a patient treated for meniscal tear. you see softened cartilage, something that goes wrong in the structure of the cartilage and is always associated with synovitis. So the two tissues are talking one each other, and sometimes there are some aspects we don't know. Also, in this case, when we treat patient, we put in evidence synovitis, and we remove synovitis arthroscopically. We are aware that the mechanism have to be faced from another point of view, from a biological point of view. So this is a response to something, to an overactivity of our sport athletes, for example. This is another type of response to sport, is fibrosis. We have to interrupt this mechanical impediment in order to put the patient in a rehab program as soon as possible. But this is an uncontrolled reaction of synovial tissue. So what are the conclusions that we can draw and we have to reflect on? The synovium plays a crucial role in sports, yes, but all the mechanisms are not fully understood. There is an interaction between cartilage and between the level of activity of our patient, and there is a lack of literature of this interplay between sport and synovial response, probably because there is a gap of knowledge concerning translational methodology that to quantify inflammation accurately in athletes. Another issue is that we have to act all together. We have to put our forces on the same table and work with a multidisciplinary approach. This is of paramount importance. Also, we have to explore other tissues that can communicate, that can interplay with synovium, such as the immune system, and to joint biomechanics. Biomechanics, it's very important. So in conclusion, researchers can uncover valuable insight researching on this uninvestigated tissue in order to obtain benefits for sport medicine. And I am convinced that the following talks, some aspects will be more clear. So I thank you very much. This is our university in Sicily, in Enna. It's our library, and this is our hospital. I'd like to thank you all. And Dr. Smerli, thank you very much.
Dear Francesco, thank you very much for this very interesting opening lecture of this webinar. I please invite the over 500 participants to take note of the questions. We will have time for discussion at the end of the talks. Now I'm very proud to introduce my dear friend Stassi. He comes from India. He's a very talented knee and shoulder surgeon, obviously an arthroscopic guy. And Stassi will talk about managing infections post-ACL reconstructions. Please, Stassi.
Thank you very much, Fabio, and Dr. Hassan. Thank you for having me here. I'm going to talk on a totally different topic, but a very important one, that is managing infection after ACL reconstruction. The problem, infection after ACL reconstruction is not very common, but when it happens, it can go haywire. We don't have a lot of experience in managing a lot of patients with infection after ACL reconstruction. The outcomes can be poor. There can be many procedures that are needed. The cartilage can get damaged and the graft can get ruptured. So we need to be clear what has to be done. Just to give you a picture, I can talk about two scenarios. Scenario number one, this is a patient, 25-year male who underwent ACL reconstruction and a slightly obese man. 2 months post-operative now, he presents with discharge in the tibial screw site, and this tibial screw is loose and it is popping out already. This is scenario one. In scenario two, it's a 35-year female who underwent ACL reconstruction, a bundle preserving one. She had a partial ACL tear, but she was unstable. She underwent a bundle preserving ACL reconstruction 8 months back. Recently, she was started on immunosuppressants because she was diagnosed to have spondyloenthesopathy. And within 2 weeks, she presented with some kind of inflammation and swelling and pain in the tibial screw site. So these are totally different scenarios. These don't get treated in a similar way. So what exactly had to be done? Let us try to understand through this talk. So I will be covering this topic under incidence, risk factors, pathogens, prevention, diagnosis, and treatment. I'm Dr. Sasinga, Professor of Orthopedics, Arthroscopy, Knee and Shoulder from India. But the incidence can be as low as 0.15% to 2.5%. It slightly varies based on region, but it's not significantly different between different continents. Many risk factors have been proposed. There's only one risk factor that has been proven without doubt, that is immunosuppressants. However, other risk factors include hamstring graft in comparison to bone patella tendon bone graft, male gender, presence of diabetes, prior knee surgery, increasing age, increasing body mass index, use of tobacco, and use of intra-articular steroid injections prior to this. A few words about the pathogens. The organisms that infect the knee after ACL reconstruction, the most common is staphylococci, forming almost 84% of infections, and that can be 45% coagulous negative staph and 39% staph aureus. Most of these are methicillin resistant, methicillin sensitive, but methicillin resistance is increasing over time. We also have organisms, infection where no organism is grown or multiple pathogens, and a small percentage is Enterococcus faecalis and Propionibacterium acnes. A few words about prevention, because prevention is always better than treatment. It is well proven now that vancomycin wrap intraoperatively on the graft decreases the risk of infection of ACL. It has been shown like it reduces the risk by 15 times or completely eliminates the risk of infection. And this treatment has been proven to be cost effective in comparison to prophylactic antibiotics. But this is not a replacement for prophylactic IV antibiotics. This is in addition to IV prophylactic antibiotic. The duration of exposure is a minimum of 15 minutes to up to 20 minutes. Gentamicin wrap has also been proposed, but it has been shown that gentamicin reduces the risk of deep infection, but not superficial infection. But if you see the overall infection incidence and the organism is primarily from the skin, and proper skin preparation is prime in ACL reconstruction. Going on to the diagnosis, the onset can be acute, subacute, or late. Mostly they present in 10 to 25 days. The clinical features are usually classic fever, fatigue, pain, swelling in the knee or in the tibial screw site, warmth, or sometimes discharge. Laboratory parameters like CRP, ESR, or sometimes procalcitonin. If the clinical signs are not very clear, they can be helpful. Knee aspiration is very important for fluid analysis and also to get a culture sample before you can start the patient on antibiotic. It has been shown that synovial white blood count has a very high accuracy when it is more than 28,000 cells per ml, and polymorphonuclear leukocytes of more than 90% can also suggest acute infection. Other diagnostic features include X-ray. When there are signs of early infection in the bone, X-ray can be helpful. Ultrasound is very useful to identify soft tissue collection in relation to the screw or the bone tunnel. MRI can be helpful in identifying early edema, hyperintensity in the bone, or collection in the soft tissue. Going on to the management of ACL infection, we have to understand that the treatment goals are primarily eradication of infection, protecting the articular cartilage, and trying to achieve full functional knee. But the primary treatment goal is not preservation of the graft. You cannot try to preserve the graft at the cost of maintaining the infection. So eradicating the infection takes the upper hand. If possible, the graft can be preserved, but if not possible, the graft has to be taken out. So what are the initial management? First, make the diagnosis. It can be clinical, but then you have to have an organism in hand. So do an aspiration. Once you have the sample, you can go ahead with early intervention, both in the form of antibiotic and surgery. Early antibiotic administration is very much important. Initially, empirical antibiotic is started, a broad spectrum antibiotic, or in the hospital acquired scenario, you can start on higher antibiotic like vancomycin and meropenem. When it comes to surgical decision making, two important questions come into picture. How many debridements would be needed, whether or not I have to retain the graft? As far as the debridement is concerned, debridement is the mainstay treatment in addition to antibiotics. So a low threshold has to be kept for repeat debridements if the signs of complete recovery are not there. If sufficient or good washout is not done, biofilm formation happens, and that can lead to persistent infection even with surgeries. With respect to graft retaining, that is an intraoperative decision made by the surgeon based on whether the graft is healthy or not. Infection eradication always takes an upper hand with respect to, in comparison to graft protection. If you lose the graft, you can always reconstruct it, but if you lose the joint, you cannot reconstruct it. Even with this protocol, majority of the infections can be treated without taking out the graft. Graft retention rates can be as high as 63% to 100%. So I would like to divide the surgical treatment options into three. The first is graft retention with repetitive debridement. This is the most favored treatment. It's almost 85% success. The second treatment option is graft removal after failure of initial treatment. Usually after the second or the third debridement of the knee, the surgeon decides to remove the graft because the infection keeps repeating or the graft have become infected and become unhealthy. This is a situation when you should not retain the graft and you should remove the graft because it's necrotic material if it is not already ligamentized or revascularized, so it is going to maintain the infection. Or the third scenario, you can go ahead and remove the graft immediately at presentation. And this is only if you already have signs of bone involvement of the infection, the graft is already damaged, or the infection is exorbitant or severe. So you don't want to take the chances of retaining the graft and maintaining the infection. Post-operatively, the patient has to be continued on IV antibiotics for a minimum of 2 to 4 weeks, and then change over to oral antibiotics until the patient is clinically and biochemically normal. Based on the sensitivity of the organism, if no organism is grown, then we have to go with a broad spectrum antibiotic. If the patient is immunocompromised, the antibiotic has to be prolonged for a longer duration. What happens if the patient does not respond even with arthroscopic debridement and graft removal? Then you have to go in with open debridement for better cleanup and better debridement. And if there is a loss of tissue, then you go ahead with medial gastrocnemius plaque in order to increase the vascularity and also to cover the joint. A survey of arthroscopy fellowship directors has shown that the initial treatment option preferred in 85% of them was debridement and graft retention. In resistant cases, in repeat cases, still they go ahead with intravenous antibiotic and surgical irrigation and graft retention. But if the infection is still persistent, then graft is removed. So the risk of graft removal for persistent infection is like as low as 6%. And after the infection is eradicated, the revision ACL reconstruction is done at a minimum of 6 months to 9 months after surgery. So take home message, the diagnosis is the key. Early diagnosis is important. All infected ACLs are not the same. For example, in this case scenario 1, the screw is already exposed. A higher grade of infection, you have to go in, remove the graft, debride well, and eradicate the infection, go in again after 6 months to 9 months for a ACL reconstruction. Again, in case scenario 2, you may very well eradicate the infection only with debridement with graft preservation, but the antibiotics have to be continued for a longer duration because of immunosuppression. Early antibiotic and early surgical intervention is very, very important. There should be a low threshold for redo debridement, repeat debridements, revision ACL reconstruction not before 6 months after infection is eradicated. Thank you very much.
Thank you very much, Dr. Sander, for that great topic. So we had two great topics and talks so far. And just before jumping to the next talk, I just want to remind again, please, we have more than 500 audience, and please take note of your questions so we can address all of them probably at the end of the lectures. So after that short note, I want to jump into the third speaker, my friend, Dr. Zimmerli. Please, stage is yours. He's going to present the synovial chondromatosis, the recognition and the treatment options. Thank you very much.
Good morning to you all. Thank you for the moderators and for all my friends to be here. My talk is about synovial chondromatosis, the recognition and treatment. Synovial chondromatosis is a benign and common condition of the synovial membrane of joints, tendon sheaths, and bursae. It is a metaplastic process that consists of multiple hyaline cartilaginous nodules in the subintimal connective tissue of the synovia. So it is a metaplasia, a process when a tissue produces another type of tissue. And the result is the formation of cartilaginous nodules and loose bodies in the joint space. Usually, synovial chondromatosis is monoarticular in the large joints and with multifocal presence in the same joint. And generally is intraarticular, but we have also an extraarticular form. The knee joint is the most affected joint, but all synovial joints can be affected of synovial chondromatosis. The etiology is unknown, but it may be related to trauma, inflammation, degenerative, or genetic factors. And we have two types of synovial chondromatosis. A primary type that occurs without any known origin, and the secondary one associated with other joint condition, like in this case. So the pathogenesis is a metaplasia. We have the production of cartilaginous tissue inside the synovial membrane. And these nodules can grow and feed in the joint space with the formation of loose bodies. These loose bodies can grow and can calcify or ossify. And the masses erode the articular cartilage and can lead to joint damage and dysfunction. Milgram classified three phases of synovial chondromatosis. The first one, when we have only an active intrasynovial disease without loose bodies. In the second one, we have intrasynovial nodules and loose bodies. And the late phases, when we have only multiple free osteochondral bodies without evidence of intrasynovial disease. The clinical presentation include pain, swelling, limited joint motion, joint crackling, joint block, the presence of these masses that can lead to deformity of the joint, and the most important sign, the presence of loose bodies. X-ray and computed tomography can show the radiopaque loose bodies, but MRI can show all loose bodies, the cartilaginous one, the ossified one, but also the synovial tissue features. So the hypertrophy, the reaction of synovia, and all characteristic of the synovia in this disease. The differential diagnostic must be done with all loose bodies in the joint. Here we can see our classification, our etiopathogenetic classification of loose bodies, because we think that loose bodies must be classified based on her etiopathology, because when we know the origin of this disease, we can do better the treatment. So it is important, the imaging, the X-ray, MRI, the CT scan in some cases. It is very important, the arthroscopic characteristic of this disease. We can see an intrasynovial nodules, a pedunculate nodule, a free loose bodies. In this case, we can see the different phases of the disease in the same case. It is important also to analyze the gross pathology of the fragment and the histopathologic features. Generally, it is not necessary, but in some cases, when we have a book, the histopathology is important. On microscope, we can see a well-circumscribed lobule of hyaline cartilage surrounded by fibrous band. The most important aspect is the cartilage cells arranged in clusters. This is typically for the synovial chondromatosis. The lesion is hypercellular with nuclear variation in shape and size, and frequent the presence of binuclear cells. And the treatment. Generally, the treatment is a surgical treatment, but in the early phases, in some cases of secondary synovial chondromatosis, in asymptomatic case, we can do a conservative treatment. But the appropriate treatment for synovial chondromatosis of the knee is the arthroscopic treatment. In some cases, it is necessary an open approach or a combined arthroscopic or open approach. The treatment consists of the removal of loose bodies and the synovectomy. The synovectomy must be the more aggressive possible. It is important to have familiarity with all access, with all arthroscopic portal to reach every compartment in the knee. Here we can see our cases of synovial chondromatosis in the ankle joint, in the anterior and posterior compartment of the ankle. The treatment was an arthroscopic remove of all loose bodies and a synovectomy by anterior and posterior approach. And in the right of the picture, we can see the X-ray at 10-year follow-up. It is very important to follow this patient and monitoring the patient for long period of time, because the reoccurrence and the complication can be verified after a long time. The open approach is necessary when we have a large fragment, and when we have severe osteoarthritis, the treatment is the joint replacement. So in conclusion, synovial chondromatosis must be recognized. The diagnosis is based on history, physical examination, imaging, and histopathology. The treatment is arthroscopy. The open approach may be necessary in some cases. The reoccurrence is frequent from 3 to 24% of cases, and rarely the lesion can lead to malignant transformation. Thank you.
Thank you very much, Hassan. Nice talk, and you've opened the talks regarding the treatment of the different diseases of the synovial membrane. Now I'm very happy to introduce Eric Stahls, that is working in the Rizzoli Hospital in Bologna, and his interest is an expert in orthopedic oncology. And he will speak about another important issue when we talk of synovial membrane. He would speak about the pigmented villonodular synovitis, how we do recognize it and treat it. Please, Eric.
Okay, thank you very much. Also from Laura Campanacci, who unfortunately could not participate. So my talk is about PVNS, recognition and treatment. And here are my disclosures. I just wanted to clarify something about the terminology, because actually pigmented villonodular synovitis and also all the other names that have been given to this disease in the past, these terms have been abandoned by the WHO in the 4th edition of their WHO classification of tumors in 2013. And now this disease is actually called TGCT, or tenosynovial giant cell tumor. We have to get used to this new term. So what is it? It's a rare neoplasm that arises from the synovium of joints and the tendon sheaths. It is a locally destructive disease. It usually involves just one joint, and we see it most often in the age group between 20 and 50 years. It's also more frequent in females than in males. As you said you saw from my previous slide, we are calling this a neoplasm. It is actually a tumor, and we know that since 2006, when West described this CSF1 gene translocation that causes the overexpression of colony-stimulating factor 1, and this overexpression from the tumor cells leads to the recruitment of inflammatory cells that form multinucleated giant cells, and this actually creates the bulky mass. But yes, it's a tumor, and you have to know that we have two presentations of this tumor. The localized form you see on the left here, it's usually just a single nodule that gets to maximum maybe 3-4 centimeters, and it's quite easy to remove. And then you have the diffuse type, which you see on the right, and there the whole joint or most of the joint is involved. And this is a whole different presentation. It has also different biological behavior because this is very difficult to remove. And this form can also grow outside of the joint and create a lot of problems to the patients. So what's the clinical presentation? Usually there is swelling. This is usually the main issue. Pain a little bit less, but over time will increase, stiffness, and generally reduce quality of life. Of course, this depends on the extension of the disease. In the x-rays, you may see the soft tissue swelling, joint effusion, the bone erosions, and on the long term, secondary osteoarthritis. But of course, if you want to study this disease, you have to do an MRI scan. This shows you the synovial proliferation, the nodules, the soft tissue masses. And what's quite peculiar for this entity is that the MRI has a low intensity signal in both T1 and T2 gradient echo sequences. And this is quite unique. Most tumors, they have a high intensity signal in T2. So this can really help you to recognize this entity. So often there is also the joint effusion, you see bone erosions, and of course the extra articular component that can be really important and can also give you problems on the neurovascular bundle in the back of the knee. So MRI is good for the diagnosis, but if you want to be absolutely sure, you have to send tissue for pathology, histopathology. This is the macroscopic appearance, yellowish, brownish tissue, nodules, and then this is the microscopic appearance. So once you have the diagnosis, we can start talking about the treatment. And here we have changed over time our behavior. We are now a little bit less aggressive in our treatment because we understand that especially in the diffuse type TGCT, recurrence is almost, yeah, it's a guarantee. So we don't want to, do too many surgeries to the patients, because every surgery has its price. And we really have to think about what is the impact of this disease for the patient on the quality of life. And if the symptoms are minor or absent, then we keep the patient just under active surveillance and try to relieve symptoms. But if the symptoms are increasing and the patient is unhappy, then we have to actively treat, and then surgery is the first treatment. Radiotherapy and also intra-articular treatments with yttrium or TNF-alpha inhibitors have been described, but this is done in very few places, and there isn't much literature on these treatments. I have no experience with that. I will come back to target therapy. That is really a novelty for this entity. So let's talk about surgery. Many of you probably have seen TGCT, PVNS TGCT through the scope. You may see these villus, and once you start shaving them off, and then your screen almost suddenly turns red because of the bleeding, and all is blurred, and it's difficult, really difficult to get this out through a scope. I think arthroscopy is good for small nodules. You can definitely use it to get small nodules. The localized form you can treat either with a scope or with open surgery. But for the diffuse type TGCT, we really have to go for open surgery, because this is complex surgery. You have to open the knee from the front or from the back or from both sides, and this is complex surgery that should be done in an experienced setting for these diseases. There are neurovascular bundles to preserve. We have to be very careful not to damage too much this knee. So this was an international global study that we did, collaboration between 31 referral centers. And as you can see, these were all diffuse type TGCTs. Almost 1,000 patients were included in this study. And although they were treated in an expert center and with quite aggressive surgery in some cases, the recurrence rate was almost 50%. So I think if you honestly should look at diffuse type TGCT, this is almost chronic. This is a chronic disease. You can try to get it out as much as possible. It will come back at some point, and you just hope that it's not going to have too much impact on the quality of life of the patient. This graph clearly shows you that once you have had a local recurrence, then these patients are at high risk of having more local recurrences. So this is very difficult to control. Also, we believe that a long-standing TGCT will eventually create damage to the joint cartilage. We see often bone erosion and secondary osteoarthritis, and this may become a problem because these patients, usually at a relatively young age, they start to have serious problems. And they may need a total knee replacement, but be aware, because we are talking about relatively young patients, active patients, and with some sort of a chronic inflammatory process going on. So these total knee replacements, they have a worse outcome than your conventional total knee replacement. We also often use constrained knee prosthesis because of the ligament and soft tissue involvement. Okay, some words about the target therapy now. This has been really the novelty in the last 15 years of TGCT research. The discovery of the CSF1 pathway in the pathogenesis has opened doors towards target therapies. And we have tried with small molecules, TKIs, like imatinib and nilotinib, to actually calm down these tumors. They had a pretty good response, but not really great. We have seen really great responses with other molecules like pexidartinib and vimseltinib that are more specific to block the CSF1 receptor, and also with the monoclonal antibodies that are now under investigation. A few years ago, pexidartinib was registered by the FDA. It was refused by the EMA in Europe because there was liver toxicity. But now vimseltinib, just a few days ago, there was a publication on Lancet from vimseltinib, the phase 3 randomized trial with very, very promising results. And this can actually, once these drugs get registered also in the rest of the world, then this may change the approach to this treatment, let's say, flowchart. So what you have to keep in mind, if you have a localized nodule, then you can do either arthroscopic or an open. They usually do well and hardly ever recur. This is the difficult group, the diffuse TGCT, and these need to be treated in an expert center, open excision, and nevertheless, they have a very high recurrence rate. So prepare for that, your patients. And once you have like an unresectable case, or you have had multiple recurrences, or you need to do very invasive surgery, now with these studies going on, we have to seriously think about systemic therapy, and this may become more of the standard for these highly selected cases in the future. Okay, so these are my conclusions. PVNS now is called TGCT. There is a localized and a diffuse type. On MRI, you can see the low signal in both T1 and T2. For asymptomatic or minor symptomatic patients, active surveillance. If you have a diffuse type, then think about sending the patient to a referral center for open surgery, and multiple recurrences, invasive surgery, consider systemic treatment. I thank you very much.
Thank you very much, Eric, for that great talk. And it's really very complicated issue, but you did a great lecture. So I want to jump into the last speaker. I'm very happy to invite Dr. Khan. He's going to talk about the recognition of benign and the malignant tumor around the knee joint. Yes, please, Dr. Khan.
Thank you very much, everyone, and a very good day to everyone wherever you are. I'm going to quickly take you through benign and malignant tumors or tumorous conditions around the knee joint. So tumors around the knee joint are very common, and they have a predilection for the distal femur and proximal tibia. They can both be primary or secondary, like metastatic disease, or on occasions, they could be hematogenous malignancies as well. Both soft tissue and osseous lesions are common. The younger population are the ones who are more prone to primary malignancies. However, in the elderly population, it is usually the metastatic disease or hematological malignancies such as myeloma, which affects these bones. Chondrosarcoma is one other entity which is quite common in the elderly population. So how do they present? Well, they can present in any age group. They can present with pain, a lump which can be painful or painless. Sometimes it's just an innocuous joint effusion, could be a deformity, any derangement in function. And if it presents very late, they can present in the form of a pathological fracture, fungating lesions, and quite common, a patient will have had a plain radiograph from some certain other condition, and it could be just an incidental finding. So let's just quickly talk of some soft tissue tumors. There are certain red flag features associated with any soft tissue tumor. So if any lesion which is bigger than 4 centimeters, if it is painful, it is increasing in size, if it is deeper to the deep tissue, or if it is recurrent, any one of these can be a red flag feature, and each and every one of these individually carries a 20% positive predictive value of this being a red flag feature for a soft tissue sarcoma. How do you investigate them? Well, they all need local and systemic staging. Local staging is in the form of cross-sectional imaging, either an ultrasound scan if the lesion is smaller than 2.5 or 2 centimeter, an MRI for the local extremity, systemic staging. And then in order to get a tissue diagnosis, we all need to do a biopsy, which in most of the places in sarcoma centers will be a needle biopsy. All these cases are best dealt with with if they are dealt with in a sarcoma center with an MDT. And if they turn out to be malignant, then they will need surgery, and they may need neoadjuvant or adjuvant therapy in the form of radio or chemotherapy. Now, there are certain soft tissue lesions which are vascular, but they do have some pathognomic features, just like this hemangioma, where you can see phleboliths, and then you can see them on the MRI scan with vascular channels in them. Let's quickly have a look at some bony lesions. Now, we can differentiate them on the location of the tumor in the longitudinal plane. So generally speaking, an epiphyseal lesion could be a GCT or a chondroblastoma or a Brody's. Metaphyseal lesion generally would be an osteosarcoma. They can be affected by chondrosarcomas, osteomyelitis as well. Diaphyseal lesions generally are cartilage lesions or round cell lesions, including Ewing sarcoma. This pictorial diagram very nicely differentiates between the types of tumor in the younger than 30 and above 30 years of age. And as we can see that in the younger population, the younger than 30 years, it's mostly those most common benign lesions that you see, whereas in the elderly population, they are mostly malignant lesions. The plain radiograph, to my mind, is the key to diagnosis for any bony lesion. And what we look for is the pattern of the bone destruction. So what we find is lesions which are of geographic pattern. They can be moth-eaten or certain permeative lesions. So let's have a look at these. On the screen on your extreme left is a lesion which has got a geographic patterns, which is a very typical of a non-ossifying fibroma or a fibrocortical defect. Then you have this moth-eaten appearance, which is a slightly more aggressive lesion in comparison to those benign lesion. And then on the extreme right, you have an infiltrative lesion with very typical periosteal reaction, Codman's triangles and sunburst appearances, which depicts an aggressive neoplastic lesion. Other things apart from the pattern of the lesion that we look for are zone of transition, any associated soft tissue component, periosteal reaction. We'll talk about this in a bit more detail, and the matrix of the tumor, whether it is chondroid or osteoblastic, which gives you an idea about the type of the lesion. So looking at the periosteal reaction, on the pictures in your extreme left, you have a solid periosteal reaction, which we commonly see with osteomyelitis. In comparison with a periosteal reaction because of a neoplastic lesion, it's not as solid or florid as this one. However, it is very difficult to differentiate between the two. Then you have the typical sunburst appearance. We have the onion peel appearance, which is very common in Ewing sarcoma. And then you have the Codman's triangles that we discussed, which are particular or specific for osteosarcomas. And when we look at them, you are looking at a less malignant or a benign lesion towards progressing on towards a more malignant neoplastic lesion. Let's quickly go through some expansile lesions of the bone. There are multiple diagnoses or multiple causes for these. We can have fibrous dysplasia. We can have multiple aggressive non-ossifying fibromas, as you can see on the plain radiograph on the top of the right of your screen. Then giant cell tumor of bone is quite common around the knee, and that is typically an eccentric lytic expansile juxtaarticular lesion, which you can see on this radiograph here. And then myeloma can present as an expansile lesion, whereas in this case, it has presented to us with a pathological fracture. Here, an epiphyseal lesion, which was because of a Brody's abscess. The giveaway here was a slightly increased ESR, and you can see the expansion of the abscess in a horseshoe-shaped manner across the epiphysis, but not crossing the physis. On the contrary, if you have a look at this X-ray here, it's again a similar sort of a lesion in the epiphysis, but this time it was a chondroblastoma in the posterior aspect of the distal femur, which we approached through the popliteal fossa and curated out this typical lesion of lesional material of chondroblastoma. Osteochondromas are very common around this region. They can either be isolated or part of hereditary multiple exostosis. One of the things we commonly look for here is the cartilage gap, and if it is bigger than 1.5 centimeters, then there is a concern raised about this having any malignant transformation. And if that is the case, then one must consider doing a biopsy first before considering any attempt at excision. On the contrary, we see here a patient who's got hereditary multiple exostosis. There are different names for this. It's also called as multiple hereditary exostosis and diaphyseal achalasia. So these are all synonymous terms. Osteofibrous dysplasia, or a spectrum ranging from OFD to OFD-like adamantinoma, and adamantinoma has also got a predilection for tibia. In this case, this patient had an OFD-like adamantinoma. Histologically, they can only be differentiated, whereas if it's a frank adamantinoma, which is a low-grade malignant tumor, it needs wide local excision. So that again is another lesion which commonly affects the tibia around the knee joint. An interesting case here where you have a patient who presents to you with a history of trauma, and there's a big soft tissue ossification, and it's difficult to differentiate whether it's myositis ossificans. This can also be a parosteal osteosarcoma or a soft tissue sarcoma. So in this instance, we did a biopsy, and this came out to be an extraskeletal osteosarcoma, which needed a wide local excision. So the point here again is that there can be various mimickers. A lot of these patients whom we see with these tumors will have an association with some sort of trauma, or they will associate with it some sort of trauma, and that generally does not necessarily mean that that is the inciting factor. However, on the contrary, in this case, this is a frank neoplastic permeative lesion with typical periosteal changes suggestive of an osteosarcoma. Now, sometimes if you have a look at plain radiographs, you might just see a rounded, innocuous looking lesion. But if you look clearly on that lateral view, you'll see a very large soft tissue component associated with it. And when you do a cross-sectional imaging, you find that this is actually a neoplastic, aggressive looking lesion, which in this case was a spindle cell sarcoma of bone. One of the other things that we commonly see is these patients presenting with pathological fractures, and the novice orthopedic surgeon, with ignoring the red flag features in scenarios like these, might just go ahead and fix them, which is a dilemma for us, the oncological surgeons, to treat. So the things you need to keep in mind are in the history, if it's a low energy trauma, or there wasn't any trauma at all, it was just a spontaneous fracture. If there was any preceding history of pain, or there was any previous history of malignancy, in which case it could be a metastatic disease. So that's something which needs to be kept in mind, and they don't need fixation. They just need to be managed along the similar principles, which in any case are, if you're in doubt, please refer them to your local sarcoma services or phone a friend. Please make sure that they're discussed in a multidisciplinary team after getting the appropriate cross-sectional imaging. And as the great man Henry Mencken said, if in doubt, do a biopsy, because if you don't, you'll be blamed. But if you do, no one will ever blame you. So do a biopsy if you are concerned. Teamwork is the key to success, and only by working in a team, you'll be able to do salvage of limbs, and whatever way of reconstruction you use, you'll be able to get these results. So in conclusion, bone and soft tissue tumors are rare. This is why they can be missed. Younger patients will usually have a primary malignancy. Elderly patients are most likely to have secondary diseases like metastatic disease or hematological malignancies. Make sure they're investigated properly, at least with some form of cross-sectional imaging. If in doubt, refer them to your local MDT and do a biopsy if needed. Please make sure you do not ignore the red flag signs in either the history, examination, or any of the clinical features that you see on your investigations. Thank you very much.
Thank you very much, Zeshan. It's been a very interesting talk. We have very, very few minutes for discussion. I'll open it inviting Sassi. You know that we are very instructional, Sassi, and you talked about repeated debridement correctly. Just to teach around the world, how soon do you go for your first debridement? Do you wait to see the therapy if it works, or you go immediately? And how do you establish when you will do the next debridements?
Okay, so it also depends. For example, let us talk about an acute ACL reconstruction infection. We should understand that the graft is in fact dead tissue and it's a growth medium for bacteria. So once you have the biofilm on the graft, the infection is going to be persistent and it's not going to go away with any kind of treatment unless you remove it. So if it is in the acute situation, as in the early infection of ACL reconstruction, then you have to be more interventional. You go in. I don't mean removing the graft. You go in, you assess the joint, do a good debridement, make sure you have removed all the pockets around in the tibia and the femur. Start on empirical antibiotic prior to the surgery if you have taken sample as in knee aspiration for culture. But if this sample is not available or you're not happy about it, withhold the antibiotic until you put in the arthroscope, take some tissue from the synovium for culture, and immediately continue with giving IV antibiotic, broad spectrum empirical IV antibiotic. But if the scenario is totally different, for example, after 8 months after surgery, you expect some amount of vascularity and healing, then you can try to be more conservative if the infection appears to be more of a soft tissue infection rather than a joint infection. If there are the minimum signs of joint infection, then you should go in with a debridement. No questions.
Thank you very much. We would have maybe many thousand questions, but I think it's over.
I have a question for Dr. Stahl. The role of biopsy in the treatment of tenosynovial giant cell, the role of biopsy. And another question, if we found an occasionally malformation during arthroscopy, what is the best strategy to do?
Yeah, so
small malformation that is not present at MRI during an arthroscopy for other region.
Yes, I mean, of course, if you have a nodule and you don't really know what it is and you're concerned, you can remove it. You can send it for histology. I think that the PVNS or TGCT often can be recognized just by an MRI. So it's not absolutely necessary to do a biopsy if the clinical presentation fits with that diagnosis, the MRI appearance fit with that diagnosis, then you can either follow it up or just remove it and do histology just to have your confirmation. I mean, it's something that is in the joint, so it's something that is anyway is inside a compartment, and if anything grows into the joint and is malignant, in some way you should remove the whole joint as an extra articular. So if you have a really strange surprise and it's all of a sudden it comes up malignant, then you have to think about removing the joint, doing an extra articular resection. So I tend to do biopsies if I see a TGCT, or I think it's a TGCT, just because it can give me that final confirmation, and I can just tell the patient, okay, it's a giant cell tumor, tenosynovial giant cell tumor. So we can either follow you up, keep you under observation if your symptoms are not too important. But if they have symptoms, you can proceed and remove it. But yeah, I would definitely send it always for histology. Why not?
Thank you.
Thank you, Francesco. I love cartilage. So when you were speaking about the overloading and in the athletes, you were obviously speaking about establishing some good rehabilitation programs from the beginning. What is your, let's say, beginning of the program? What do you suggest when you have an athlete in your office and you need to start the treatment?
Well, I strongly believe in pre-rehabilitation. I think that if you have if you are lucky, I think to observe the patient in an early phases, you have to address your treatment not only on the cartilage but also on what is all around the knee. And now we are focusing on muscles, for example, here in Sicily. And I think there are a new perspective concerning, for example, vitamin D or all that supplements associated with physiotherapy that were in the past addressed to the bone, to the cartilage. So I strongly believe in collaboration between us to interpret this interplay between different tissues.
Thank you.
I have a question to Hassan. Thank you for the great talk. I'm curious about your indications, open versus arthroscopic excision of the synovial chondromatosis. When do you decide to open the joint?
The open treatment is necessary when we have a big fragment. And in some case, if the history of the disease, when we have an aggressive synovial chondromatosis, maybe it is necessary to do an aggressive synovial. This is the two indication for generally the dimension of fragment. But also we have a form of aggressive synovial chondromatosis. In this case, it is indicated. And also in other joint, it's more indicated the open. But in the knee, this is the two indication.
Hassan, me too, I have a question for you and maybe also for Eric. When you get into the joint and you obviously plan the surgery to treat your synovial issues, depending on who of you is treating the problem, obviously the different problem. What's your idea? You get in the OR also with some cartilage instrumentation ready to do a one-step surgery if you find some cartilage defect or damage, or you just treat the synovial issue and then proceed for eventual repair of the cartilage defect in a second stage surgery?
In case of synovial chondromatosis, we can do the treatment of cartilage because synovial chondromatosis is a benign disease. It's a tumor-like disease. It's not a tumor. And the reoccurrence is after very long time. So it is important to treat the other lesion inside the knee.
Yeah, in TGCT, I think it really depends. If it's a localized small nodule, then you can easily combine that with other treatments. If it's a diffuse type TGCT, I would avoid doing other treatments at the same time.
Okay, thank you very much. I think if there's no question from Ghazi, have you any other question? I think we are.
Thank you very much.
Plenty over the time, so I'm very happy. We had a very interesting session. I please invite all the participants. You can, as you see, the QR, you can have through the QR, you have the chance to have the certificate of attendance. And obviously, we wish that all of you will fill up our post-webinar papers in order to have your opinion and your suggestions about our work as SICOT Pioneer. So thanks a lot once more to Hassan for having created the idea of a very interesting and non-usual disease pathology in the meetings. Thank you to all the faculty from all over the world, and thank you to all the participants. Please continue following the SICOT activities and enjoy the weekend. Bye-bye to everybody.
Bye-bye.
Thank you very much.
Thank you very
Bye,
much.
everyone.